And our work is particularly interested in how relevant PopART is to that big main third of UNAIDS long-time goals, which is to do with heading towards zero stigma and discrimination. I'm not going to spend enormous amounts of time on this call because I think many of the people here know a lot about stigma, but I'm going to do a few slides quite quickly on definitions of HIV-related stigma. I quite like this definition from Lincoln Phelan, which identifies stigma as a process going on in communities and settings that involves the co-occurrence of labelling, stereotyping, separation, status loss and discrimination in a context in which power is exercised. And their definition pulls out that discrimination is a constitutive feature of stigma. It's not the only feature, but discrimination both at individual and at societal or structural level is something that is a constitutive feature of stigma. HIV-related stigma manifests, Lincoln Phelan talk about stigma in relation to all things, and this slide is intended to kind of pull out some of the key aspects of HIV-related stigma. HIV is perceived in that framework as a label that's applied to people, and that label comes along with some bad things. It comes along with a series of negative stereotypes. Many of those negative stereotypes are to do with sexual behaviours and behaviours that are not perceived to be okay in societies. And because of that stereotyping, the acquisition of an HIV label is linked to status loss. HIV is also feared, and that means that people labelled in that way are often avoided or themselves isolate from other areas of society. And both individual and structural discrimination have been described as being present in many settings, in the form of gossip or insults or even more serious discriminatory acts against individuals. And there is at the structural level, there are issues to do with criminalisation and restrictions of travel, etc. And the power relations, there are several power relations relevant to this going on. One is to do with what's okay and what's not in the world of sexual behaviour, and a lot of this stereotyping that goes on with HIV comes from norms to do with sexual behaviour that are perceived as being okay or not in communities and health settings. And one particular area we're interested in is in the power relations to do with individuals accessing health systems. It's been reported repeatedly in the literature that health settings can themselves be places where stigmatisation occurs, and also that health workers can be vulnerable to stigma and to stresses associated with that. And as you'll see as we go along, those are things we're keen to investigate. The presence of stigma in communities can also lead to a couple of other things. It can lead to people anticipating the negative consequences of acquiring this label, whether that's rightly or wrongly that they've been given that label. And it can also lead to the internalisation of some of these negative stereotypes by those who have these stigmatised traits. People can begin to believe that the bad things that are said about them are true. And these two things in turn can influence several things. They can influence mental health, and they can, through that process, and more directly influence physical health. But as you'll see, we're particularly interested in this study in the way that anticipation and internalisation influences health behaviours. And we're particularly interested in how it influences patterns of testing and access to treatment and adherence, and many of those things that make up the UTT intervention in PopART, which I'll tell you a little bit more about in a minute. This is a very nice framework from my colleague Anne, who I mentioned earlier, that articulates the kind of several levels at which stigma operates and the processes by which it operates in communities. Many of you will have seen this before, as it's fundamental to the stigma measurement brief that Anne wrote for Strive a while ago. Which leads me on to stigma measurement, and I'm going to mention Anne again as somebody who's been very involved, particularly with her colleague Nora Nyblade, in thinking about measurement of stigma as a phenomenon. It's obviously a complex thing involving multiple domains, And most commonly, the most common items are those in the DHS, of which there are 4 questions. Many of you will be familiar with those. They relate to things like whether or not people feel it would be okay to buy food from somebody who's HIV infected, those sorts of things. In practice, Anne's recent review found that in many studies that were done on stigma, people had measured it in an enormously varied ways, scales that had from between 1 and 61 items in them. And that's really proving increasingly a bit of a barrier to synthesizing literature on stigma. And so we've both been involved in, Anne's been leading a process trying to harmonize the way in which stigma measurement occurs. And as you'll see, that's something we've wanted to bring into our work. Colleague Nora Nybraid has been particularly involved in such efforts for thinking about stigma in health settings. So within the context of the PopART trial, which I'm going to tell you a little bit more about in a second, our aim is to collect mixed method data on these different domains of HIV-related stigma and how this changes over time, and to use that data to analyse how HIV-related stigma affects and is affected by the process of implementing PopART. And we want to do that analysis integrating data from many sources, which I'll tell you about in a little while. PopART is a combination HIV prevention intervention that includes an attempt to implement universal test and treat. The key constituents of the PopART intervention are listed on the slide here. PopART recruits a new cadre of health workers. They're known as CHIPs, Community HIV Care Providers. And these individuals, their primary task is to conduct annual rounds of home-based voluntary HIV testing and counselling. And that annual round of home-based testing is the gateway through which other aspects of the PopART intervention come into play. So a key thing then is to refer people on to appropriate services and help them link into services that they may need. Now that might include prevention services for people who test negative, such as medical male circumcision or PMTCT. But for people who are positive, it includes active linkage to care into the health system for HIV treatment. And it includes promotion of a range of relevant services to do with sexual health and TB and distributing condoms, etc. That's the kind of backbone of PopART. What happens when people who are positive get to health services is another key aspect of the intervention. And the trial has 3 arms. There is a standard of care arm, that's known as Arm C, in which the package is not happening. In Arm A, which is perhaps the one that creates most interest, this annual rounds of testing and counselling and referral into services is accompanied by the decision to put people onto antiretrovirals or offer people antiretrovirals irrespective of CD4 count provided through their local health centre. So people who test positive through this home-based testing are referred to local health centres, and irrespective of their CD4 count, they are offered immediate ART. In Arm B of the trial, the home-based testing and all of the referral activities occur, but people are put onto treatment or offered treatment at national guidelines in South Africa and Zambia, the 2 countries, which of course may change over the course of the study, but that's what will be applied. That's a description of the main PopART intervention package, and of note for our purposes, it doesn't include any particular focus on HIV-related stigma. It has no other intensive stigma reduction components, and it makes a virtue of the fact that it intends to be universal rather than targeted. There's no component of it that directly seeks to target specific social groups, such as high-burden groups such as sex workers, etc., which has been a common feature of programming for HIV. PopART intends to be universal. The next slide just describes the trial design. I don't want to go into that in any detail here, but the impact of these interventions will be measured in a very large cohort of individuals, around 52,500 people, and HIV incidences will be measured in these 3 arms over 3 years. That's the primary aim of the trial. So for our group, we have 3 kind of guiding, competing hypotheses in relation to how stigma might affect and be affected by PopART, and they're listed on the screen here. I want to go through them in a little bit of detail each. On the left-hand side, firstly, it's stated in the PopART protocol, and one very real hypothesis that we're interested in is that PopART, the interventions that comprise PopART might themselves reduce HIV-related stigma. The text below that on the slide is a direct quote from the protocol, and it says, because the main intervention in 071 is universal and is offered to everybody in the community, it will obviate the need for specially targeted interventions for different risk groups, and therefore should help avoid stigmatisation and encourage community-wide support for HIV prevention and care. Now, if this is true, you can conceive of this UTT combination prevention approach as a stigma reduction intervention. If it's true that by working in the communities in the way that it suggests, it does reduce stigma, you can think of UTT as a stigma reduction intervention. The middle bar column relates to another possibility, and that's that PopART actually might increase stigma rather than reduce it, or at least change the forms it takes. What will happen with if the PopART intervention is successful in its primary aims is that many more people will learn their HIV status and go on to treatment. And it's not a far leap then to imagine that if many more people learn their own status and start treatment, that many more people will learn about other people's status. And if HIV infection therefore becomes much more visible in communities, as people know their HIV status and start ART, this growing visibility might be accompanied by increased levels of labelling and marking and negative stereotyping and those constituent features of stigma. And that's another hypothesis that we're keen to follow through. And the third is that the presence, the pre-existing of HIV-related stigma in the PopART communities might inhibit the capacity of PopART to work. It's been well described that HIV-related stigma is an important phenomena both in Zambia and in South Africa, where these studies are ongoing. And there's lots of literature to suggest that stigma acts as a barrier to the acceptability of people testing for HIV. It may act as a barrier to people starting ART early and to adhering to their medications. And so it's possible that stigma might end up being an explanatory factor if the UTT intervention fails to achieve its aims. And in both of these last two scenarios that I've described, these extreme scenarios I've described, then you might conclude at the end of the study that additional complementary effective stigma reduction efforts are essential if something like universal test and treat is going to work. And the role of the work that I'm going to describe to you now is to try and be able to say something about the relative importance of these three hypotheses at the end of the trial. I'm not going to dwell on this slide. It's an intention to kind of visualize the interactions that make up stigma. Again, I can come back to that. So what does our study comprise? It's a nested evaluation nested within this trial. It comprises mixed methods approaches. Increasingly, we're beginning to see how it's relevant to the growing interest in implementation science, and I'll show you a little quote in a minute that articulates the resonance of that idea to our work. We are conducting prospective data collection throughout the duration of the PopART trial, and that includes data collection of two main types. This new grant that we have, this ancillary grant from NIMH, is specifically to conduct work for this, to investigate these hypotheses, and focuses on health workers particularly. I'll tell you a little bit more about that in a minute. And in the future, we hope will also involve some quite detailed work with key populations. And the second key component of our data collection strategy is to nest within things that are going on in PopART anyway, questions that will help us achieve our aims. And I'll tell you a little bit about the PC, the population cohort, and the CC, the case control studies, and the social science endeavours in a second. And that final bullet point on this slide is quite important for us. It almost is the thing that captures our study design. We want to make sure that we do two things. Firstly, as I mentioned before, we want to use these harmonised, well-understood, tested indicators of the different domains of HIV-related stigma, and that's key to our approach. And the second is this idea of parallel assessments. As you'll see, what we seek to do is capture aspects of stigma as it happens in communities from many different perspectives. And as you'll see, that includes asking similar questions to health workers and to people who live in communities and to people who live in communities and are also living with HIV, etc. And that idea of parallel assessments is quite core to our work. Here's this quote in relation to implementation science. I don't want to talk about that in any great detail, but just this quote here: implementation science seeks to understand the behaviour of healthcare professionals and other stakeholders as a key variable in sustainable uptake, adoption and implementation of evidence-based interventions. That's really quite aligned with what we're trying to do, and we're trying to borrow from that framework wherever it's helpful. This slide, I'm going to talk about all of the things on here in a little bit more detail over the next few slides, but this is a summary of the data collection aspects of our trial. On the left-hand side are the various groups of individuals that we will collect data from. You'll see they include health workers, community members, people who do and don't accept testing, people living with HIV, etc., etc. And you'll see that in each of these groups, the bottom row refers more broadly to the context in which the trial is happening and stigma reduction efforts happening in the study communities. In relation to each of these rows, we have data collection nested of both quantitative types, and some of the key things that we're trying to get at, which I'm going to tell you a bit about in a minute, are listed in the column there, and qualitative data. That's a little bit cryptic what's in that column, but it relates to the different components of the social science aspects of the study, which I'll say a little bit more about in a minute. This is just a summary of the populations that we seek to look at, and that we're collecting both quantitative and qualitative data from these groups. I want to tell you a little bit about this health worker aspect. It's the main thing we're newly being funded to undertake. We want to describe and develop from these harmonised indicators scales to measure and to explore determinants of HIV-related stigma amongst health facility staff and these new cadre of CHIPs, these community health workers, who are involved in the delivery of PopART. And as you'll see, we want to use that data to try and see whether levels of stigma amongst this particular population differ between the trial arms, that's what the second bullet point says, and whether these things are related to how successful the delivery of PopART and the uptake of the UTT intervention is. That's what the third bullet point says. And we want to do that by contextualizing quantitative data we collect through qualitative research. So what's our study design? Well, our study design is to, in all 21 clusters of the PopART trial, to recruit to a cohort study, a longitudinal survey, all of the community health workers, these new CHIPs, they're present only in arms A and B, and all of the health facility staff who are involved in the delivery of testing and treatment in these communities. And we think across both of those groups the total number is around 1,200. We decided to recruit all rather than a sample, or try to recruit all of these individuals rather than a sample. And what we'll do is we've developed a data collection tool, which I'll say a bit more about in a second. It will be delivered on an electronic self-interview. A tablet computer will be given to these individuals to answer questions themselves. And we'll do that during the first year of delivery of PopART, after 1 year, and at the end, towards the end of the trial. Our data collection tool is changing daily. Actually, Anne has just finalised it actually this week. This is a slightly old, but it still tells you about the main areas that we seek to investigate in this tool and gives you a sense of, rather than a precise number of questions. From each of these health workers, we seek information about who they are, their socio-demographics, a number of items about what they do in their job and about the environment of the health, where they work. That's both in facilities and for this new cadre of community health workers. We want to find out about their own experience of HIV testing, and some, particularly of the community health workers, will themselves be HIV positive and may have themselves experienced stigma. Others might have experienced stigma and discrimination as a result of being involved in the care of people living with HIV. And then the bulk of our questionnaire is down at the bottom there. You'll see we have a large number of questions. I'm going to show you a couple of examples in a second of what we call perspectives, and they're attitudinal or questions about stigma in the workplace. And we also have a big focus. We're particularly concerned about other aspects in the lives of these health workers that might influence the delivery of PopART. And we have a big focus on job stress, which I'm not going to talk so much about today, but that's another area we're keen to follow in this group over time. Here's an example of some of the things that we get those health workers to respond to. We would get people to respond to these on a 4-point Likert scale, from strongly agree to strongly disagree. and you can see some of the examples of those. Many, there are around 50 to 60 of these items in the questionnaire at the moment. People read these statements and respond to them from their perspective. For example, people living with it or thought to be living with HIV are talked badly about. You would have seen questions like these before, I'm sure. Words in the different colours here, the red and the blue and the green, you'll see in a second that those same wording appear in different aspects of the data collection tools with different people. And that's what I mean by this parallel data collection. You'll get a sense of that in a second. But we ask these same phenomena, not just of health workers, but of people living in communities and people living with HIV, etc., from their different perspectives. So you get a sense here of the sorts of things that we're interested in. The next slide just tells you a little bit about our current thoughts with relation to qualitative research. In this aspect of the work, we plan to do a longitudinal qualitative research program with also with health workers, around 40 of them, as shown on the slide here, and to get a bit more detail about how their interactions on a daily basis and other aspects about their working life influence their perception and experience of stigma in health settings. And we have a big focus also on trying to ensure we do a good job of documenting what else outside of PopART is going on relevant to stigma. We're well aware that the PopART's not the only thing going on in these communities, and that it may well differ quite a lot between different communities what other stigma reduction type interventions are happening, whether they're delivered by the health system or by NGOs or whatever. And we want to try and ensure that we capture that. Now, the next few slides I'm going to also whip through fairly and not dwell on them. Again, I thought it was useful to have them to refer to later. What they say is that there are, of course, ethical issues in conducting research with health workers, in particular health workers, some of whom work for the same organisation as the researchers. The CHIPs in particular, an institutional link between us as the research team and them as workers. And these next few slides, which I'm not going to talk about in any detail, detail some of our thinking and our procedures, trying to minimise the risks to participation in these studies for these health workers. We take quite seriously those dynamics and have thought about them a bit. I wanted to end, though, by telling you a little bit about this idea of parallel data collection in other groups, so you can get a sense of the whole, or all of the components. Firstly, stigma is also a key theme for the main, if you like, PopART social science group. That's led by Ginny Bond, who I mentioned earlier, who's a co-investigator on the stigma work, but leads the main social science components. They're undertaking many activities in these study communities, from ethnographic research in some communities to rapid appraisals in others, to participatory work and in-depth interviews, with a particular focus on understanding how the trial is perceived and implemented, and some aspects of the accessibility and acceptability of the interventions as they happen. So it's like many qualitative research programs nested in trials, it's multi-methodological. And for them, stigma is a key theme. So I'm not going to go into detail into the social science work, other than to say that stigma is a key theme that forms part of the focus of their inquiry, and that the stigma group is heavily involved in the design of these qualitative research processes with community members and with people uptaking the interventions and those not uptaking interventions, and also in the prioritization and conduct of the narrative analyses that will unpick how stigma manifests in those interactions. So there's a big set of stigma-related stuff that's going on in the qualitative work more generally. Quantitatively, we have nested a load of questions in relation to stigma in this population cohort. Those questions have asked of a random 20% of all PC members, and that still ends up being a sample size of around 10,500 people across the whole study. Those questions, in line with this idea of parallel data collection, are collected on the same scale as the ones we're implementing with the health workers. And here's an example of some of those items that are asked of community members. And as you're getting to the end of the slide, again, I kind of want to highlight this idea of parallel measures. Those motif wordings in red and green and blue, those motifs appear in the health worker studies, in the community member studies so that we get at the same phenomenon from different perspectives. That's their idea. You'll see that again in our work with people living with HIV. Individuals in the population cohort are asked at baseline to identify, to report whether or not they're happy to say whether they've previously had an HIV test and then to share the result. So the PCE is limited in the sense that it only self-identifies people living with HIV. But those people who do self-identify are asked about their own experience of stigma and discrimination in both communities and health settings. We think there will be around 150 to 200 people in each cluster who answer these questions. So you can see the total sample size there. And again, this idea of a 4-item the strongly disagree approach is used again for many of these questions, or a different approach that's based on the frequency of things happening. And as you can see again in the next slide, see these motif phrases, these same parallel phrases that occur in all of the different aspects of the work. The case control studies, I mentioned only 2 of them here. There are actually 3. These case control studies recruit people who do and don't take up aspects of the PopART intervention. One happens in year 1 and relates to whether or not people accept or do not accept home-based testing. And so those people, a subsample, it's 400 testers and 400 non-testers, are randomly selected from people offered these interventions, and comparisons are made between characteristics of these who do and don't accept testing. And that will include also questions that relate to how important stigma and anticipation of stigma was in their decision to accept these components of the intervention. A second case control study looks at people who do and don't take up the offer of immediate ART in Arm A. And a third one, which I haven't mentioned on this slide, relates to the uptake of the offer of repeat testing in year 2. And all of these will have nested data in relation to the same parallel stigma-related phenomena as those I've mentioned before. The final bits that we're still thinking about and haven't really planned out in full detail yet, we're very conscious at the moment that the group that's missing in our work are those key population groups who themselves are stigmatized because of their participation in groups such as MSM and female sex workers, but also because of those links to HIV that are perceived for those groups. And we are still thinking about and discussing and working what we might be able to do in later out years of the trial to go and do some quantitative data collection, perhaps using methods like respondent-driven sampling, to go and collect some data on uptake of the UTT intervention and stigmatization from these groups directly. Very near the end now, so finally, just to reiterate, what are we going to do with all of this data? I think it's fair to say that that's also a work still in progress. But at the heart of our analytic strategy are 3 things. Firstly, to compare these indicators across the trial arms to get a sense of those first 2 hypotheses. Do these different conditions in arm A, B, and C lead to an increase or a decrease in these stigma indicators in these different groups? A second set of analyses will try to pick out whether or not HIV-related stigma is an important factor acting as a barrier to the implementation and uptake of the PopART intervention. So those analyses will have to break the randomization, but try and be a bit more creative about using these data to try and get at that question. And a third kind of core aspect is to try and integrate the qualitative and the quantitative data. Final slide then. I don't need to go through the conclusions. I just wanted to tell you where we are. The protocol for the health worker study is now approved through DATE and registered with the HPTN. We're very close to a finalised questionnaire for baseline for our health worker study. And the community members work, the population cohort work, which also recruits these people living with HIV, is actually already in the field. That's underway. Finally, the data collection for our health worker study will start in June, and as I mentioned, our future work on key populations is under discussion. Maybe I'll stop there and hand back to Laurie, and I'm happy to take questions or have a conversation with anybody about any aspects of this. So I'm just going to read it out because I'm reading it at the same time as you. How will you control for the background levels of changes in societal attitudes to HIV that have nothing to do with PopART over the period of the study? They may well be very different changes in different places, even within one country. How will you measure these background changes, which may not be linked to particular local NGOs or other activities? So I suppose my answer is, okay, so I'm going to ignore the thing about controlling. So firstly, will we be able to get a handle on whether or not, in the absence of the PopART interventions, some of these aspects of stigma change over the course of the study? And I think the answer to that is yes, because we're in the good position of having a standard of care arm. We have 7 communities in Arm A, and they include communities in both South Africa and Zambia. And so, one way of thinking about getting a handle on how things change over time in ways that are unrelated to the intervention is to see what happens in those communities. How will we control for that? Again, I think in relation to our first set of analytic aims, I don't think we will need to. I think the randomised design, where we compare what happens in Arm A, B and C, will allow us to be able to get hold of what changes are to do with the interventions and what are background changes that are less interesting for our purposes. Then, when you get into my second analytic aim, then I think your question will be a complication. When we're trying to pick out whether places have different levels of kind of pre-existing stigmas and whether those change differently over the course of the study, and whether either the baseline or the change over time influences how well the implementation goes, those non-randomized analyses, I agree with you, that will be a complexity, and I suppose we as a team are still thinking about that, but we hope we've got the data at least to get it.
People ask if the slides would be available, and if you look at your chat box, you'll see that on our website at strive.lshtm.ac.uk, you can find both the slides and copies of the podcast once it's edited. You can also see and watch all past webinars, so I encourage people to take a look at that. So in our chat box, we have a simple question, but I think an important one, which is, can you clarify where the trial sites are, James, in South Africa and Zambia?
I can't. I'm not going to detail the place names. I don't think that's appropriate here, but I am happy to say that all of the sites in South Africa are in the Western Cape, whereas the Zambian sites are spread all over the country.
And could you say just a bit about your decision not to reveal the particular sites? Because that's an important sort of discussion point, I think.
I'm not sure that there would be any benefit to talking about the specific places. There's nothing in particular sensitive about that. I suppose I'd want a really good reason to be talking about particular places, and it may well be that that's public knowledge. I'm a bit uncertain. There are maps in the main protocol. I'm not sure that that's useful here right now.
Nambusi Kayakombi, who is in Uganda, she asked, will you be measuring changes in internalized or self-stigma, which will likely affect individuals' willingness to seek treatment?
So the answer is yes, with the caveat the caveat that's across all research of all types and is true here, that we're limited in the number of questions that we have. We have one or two, I think it's as possibly as many as 3, but not very many items nested in those PC questions that are asked of people living with HIV. They're quite well-tested tools. There's precise wording of which I don't have at my lips now, but would certainly be happy to share. But they get at the idea of internalization of stigma, internalization of negative stereotypes. And so, yes, we would hope to be able to use those to analyse whether or not that influences the uptake of the UTT interventions and whether or not they change over time and across the arms.
Priti, a colleague from India, she's interested in hearing about how the community health workers actually recruit people into the it's not clear if she's interested into the primary study or the sub-study, but perhaps you could speak to both of those issues.
So maybe I could take the second part of Britty's comment first, which is she says, I understand there's no separate stigma reduction interventions. Kind of for the purposes of this talk, I overemphasize that. A key component of the CHIPS training, and of course a thing that many health workers in facilities are likely to have gone through recently or more distantly in the past, is training in relation to stigma, how dealing with issues about providing HIV-related services and dealing with people with HIV. And so it's not that PopART arrived and that hasn't happened before, and that is a component of the CHIPS training. But there isn't those two things are true, that there isn't a specific component of PopART that's kind of detailed as a major component that's community-based activities or things that with the primary goal of reducing HIV-related stigma. And it's also true that there aren't these targeted interventions. The rationale for which is often to get past stigmas that prevent people like MSM using services. So what the CHIPS tell people in the community to recruit them in the study? So I'm like you, Laurie, I'm unsure whether you're talking about the kind of consent to participate in the study or consent to uptake the interventions. But what the CHIPS do is go from house to house, and they offer HIV testing in the home, and then active linkage to care after that. They do that guided by an intervention manual that explains how the services that they're supposed to offer and how they're supposed to go about that. And as I say, that's influenced by prior stigma-related training. Previous experience in lots of places that home-based testing has enormously high uptake where it's been tried. And that's one of the key rationales for PopART, is that where home-based testing has happened, you can achieve very high levels by taking away the need for people to actually actively seek out testing in health services.
Okay. We also had a question about when you expect the reports to the results to report out.
The study's just getting underway. The final, it's going to be some time. Obviously, baseline data seek to present that and hopefully publish some papers on what we find at baseline in the next couple of years. But the trial main reports, I would imagine, are more like 2017, 2018, that kind of timeline. This is the beginning of an endeavour rather than being a long way through.
So we have a question from Catherine Dodds, who says, your description of the parallel data collection along the lines of the similar stigma motifs is interesting, she notes. Can you describe the process whereby you arrived at a decision about these particular motif components or these particular, as you said, the kind of word clusters that you repeat? Anne, would you care to take that question?
Yeah, just a quick recap of that process to develop those harmonized indicators. It was a 3-year process that started back in 2009 and was supported by mainly by UNAIDS, and we had a number of meetings of sort of key stakeholders, researchers, affected communities, to look over all of the many measures. There were about 1,000 measures that we ultimately started with at the beginning of the process, and we had to whittle it down to a very small number. And so out of that initial meeting in 2009, we came up with a 16-member working group that was representative of researchers and affected communities from around the world, and we worked for about 2.5 years to develop and field test measures. The main purpose of that effort was to try and develop measures that would be useful for assessing stigma discrimination in general populations. So mainly in the demographic and health survey, we were really trying to come up with better measures. Ultimately, we also wanted to influence research and programmatic measurements, but our main thrust was to try and develop some new indicators for the global AIDS reporting on progress indicator set that all UN member countries are required to report on. And so that process has actually just ended. In December, we had 3 indicators that we had developed and field tested, approved by the UNAIDS Monitoring and Evaluation Reference Group. And so some of those motifs that James has shown you those come from those questions. We have slightly altered them to change them to be in a Likert style format because we're using them for research purposes, whereas the DHS questions are more yes/no. But that was the process that we went through. And I also should say that the measures that assess internalized stigma and some of the key domains for people living with HIV were developed alongside colleagues at the Global Network of People Living with HIV who have measures similar to this in the PLHIV Stigma Index. So we feel pretty confident that the measures that we have that came out of that process are going a good way towards assessing all of the key domains of stigma that we know that we're able to shift through programming. And that's really what we were ultimately trying to do, to understand which of how to measure each of these key domains that we need to understand in order to be able to reduce either the drivers of stigma or the manifestations of stigma.
We have a final question here, or observation here from Paul Mee. He notes, also, any thoughts on how the project might increase healthcare workers' workload and how this could increase negative attitudes to those with HIV? Locally, we have anecdotal evidence that healthcare workers may discriminate due to perceived risk of infection and the perception that they should protect colleagues, for example, from needle stick injuries. So not a moral judgment per se, but perhaps a fear-based response. Will your questions be able to distinguish this from other aspects of stigma?
Yeah, we actually have a bunch of questions in the survey that were developed by Laura Nyblade and colleagues at Health Policy Project that get at just that. There's several questions trying to understand worry that healthcare providers might have of becoming infected with HIV during various procedures that they might be doing in the health facility, and also related to unnecessary precautions that they might be taking just with people living with HIV, not with other patients. We have questions to get at their understanding of universal precautions and all of that. So I do think that we have fear is one of the key domains that we want to understand, because that's an important driver, as Paul noted, of healthcare providers' sort of reticence to sometimes, engage with people living with HIV, or their willingness to want to treat them. So yes, we should be able to understand that area pretty clearly, hopefully.
Can you go back to the slide that has the definition, the original definition on it? Because one of the questions I've often been thinking about and wanted to get your thoughts or James here. So the co-occurrence of labeling, stereotype, separation, status loss, and discrimination in a context in which power is exercised. Are there elements of that definition that you think are more, that make something stigma versus another type of discrimination? So, for example, if I think, and we've had this discussion a little bit, if I think about, let's say, gender, associated in certain contexts, there will be status losses, discriminations, stereotyping in the context in which power is exercised. The piece of it that doesn't seem to fit, for example, with gender or some of the things, is this kind of marking notion or the fear-based notion. And I wondered if there's been discussions within the stigma community about, are there certain processes which are more fundamental that would make something stigma versus some other social process of discrimination or something that we might not normally think of within a stigma domain?
I think, Laura, you kind of hit the nail on the head that one of the key components is labeling when it comes to the stigmatization process. As you rightly noted, stereotyping and separation and status loss can really occur for a number of reasons, but it's really that labeling piece where someone is sort of marked in some way as different from the norm. and that it could be a case where gender is a part of that. But for example, if you're a female sex worker and you're being labeled as a sex worker and then set aside as different from others, then you can have this whole stigmatization process occurring. But what Lincoln Phelan thought was in their particular conceptualization, all four of these things need to be present at the same time to be able to think about what's happening as stigma and the stigmatization process. So a lot of these individual bits of this statement happen all the time, but if they're not happening sort of together, or if all four things aren't present for a certain individual or group, then we wouldn't normally think about that as stigma per se. And just to note, there are many, many definitions of stigma, and James picked one of the most popular ones, but there are a lot of different ways of thinking about this. But I do think that it's really that labeling bit, that first piece of the marking that's really specific to the stigmatization process, whether it's related to HIV or some other behavior or condition or risk groups, for example.
Right. Maybe Laurie, just one thing to add. One of the reasons I like this definition actually is because the same people it links in, I think, to the sort of social epidemiology world that I have spent a lot of time reading about. And Lincoln Phelan also have this idea of fundamental causes. I don't know if you know that literature, but so they think of gender as a fundamental cause of health inequalities. And the paper does quite nicely links what the process that they're describing as stigmatization and their work on fundamental causes.